Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
I am Dr. Black, so I see you have come with chest pain and some shortness of breath.
Oh, yes, doctor. I just don't feel quite right. I've had this pain in my chest for a week now, and I've been feeling...
And how are you feeling right now? How bad is the pain?
I've not had anything like this before, but right now I feel okay. I mean, I've got some niggling pain, but it's settling after some paracetamol, and I'm not breathless at the moment.
And so I'm going to ask a few questions about the chest pain. So first question, where is the chest pain? And what kind of pain is it? Dull, sharp, crushing, constant, or intermittent?
The pain is a niggling, sharp pain on the left side of my chest. It's there all the time, and ibuprofen and paracetamol don't take it away completely. I mean, I would say it's about 4 out of 10 at the moment.
Does anything make it better or worse, such as deep breathing or leaning forward?
Well, when the pain first started, I just sat on the sofa and I've noticed it's the breathing that bothers me more. I just feel I can't catch my breath. Then, when I take a deep breath, the pain is worse. Also, I can just about get up the stairs at home, but I have to sit down and rest. If I'm walking more than a couple of 100 meters, which is not like me at all. I've always been very fit. I mean, I've never had any problem with lungs or heart.
And have you had any other symptoms, such as a cough, fever, or wheezing? No?
No, I mean, I thought it might just be a chest infection at first. But I've not had a cough, and I'm not feverish, so I'm not sure. I definitely know wheezing.
So, Ms. Campbell, you said you have no history of chest pain or heart problems, correct?
Correct. I've never had any heart problems in the past or while my mom had a heart attack at 76. As I said, I'm normally very healthy. The only thing is I had a hysterectomy 3 weeks ago, but no complications, and I was home within a couple of days.
So based on what you have told me about your recent surgery and other factors, you're at risk for a pulmonary embolism. In order to be sure, we will need to run some tests. I'm going to order an ECG and our CT pulmonary angiogram.
What is that, a pulmonary embolism?
A PE, as we call it, involves a blockage of the pulmonary arteriole. Tree by something that has traveled from elsewhere in the body through the bloodstream. Usually this is due to a blood clot from the deep veins in the legs. Symptoms include difficulty breathing and chest pain, and clinical signs include a low blood oxygen saturation, which you are not exhibiting yet but are on the verge of, as well as tachycardia, which the ECG will show.
Doc, will I need surgery for this?
Rarely is an open pulmonary embolectomy performed. A pharmacological treatment is the most common type of management. In fact, while we work to confirm the diagnosis, we're going to start you on a low molecular weight heparin and anticoagulant commonly used for PES. Then once we get the imaging results, we can make a final decision. Well, what additional methods are needed to achieve adequate anticoagulation? Any other questions before we get started?
Yes, one more. If it is a pulmonary embolism, is this an ongoing problem or?
Well, because of your recent surgery, it is likely a provoked pulmonary embolism. The treatment will likely last at least 3 months. At that point, we would assess the risks and benefits of continuing treatment.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. Please be seated. Is she your daughter? What's her name? And what's her complaint?
Her name is Tiara. She gets shortness of breath with vigorous play and exercise. She gets tired more quickly than the children of her age.
Does she have coughing, wheezing, or chest congestion? What's her age?
She is 6 years old, doctor. Moreover, when she runs in races, she seems to have severe problems. It seems to take her a significantly long period of time to catch her breath.
Was she admitted to any hospital earlier?
She needed an apnea monitor after birth, and this was continued for approximately 3 months thereafter. At times, she has nasal congestion during the night and morning hours.
What medications is she taking now? Is she allergic to any medicine? Are her immunizations up to date?
Yes, doctor, but she is yet to have the influenza vaccine.
Her pulmonary function test shows premature ventricular contraction. It is 1.21 liters, that is 77% of predicted. The FEV1 is 1.9, that is 81% of what we've predicted. Peak expiratory flow is 175 liters per minute, that is 82% of predicted post-bronchodilator. She has no change in the forced vital capacity 1. She had a 10% improvement in the peak expiratory flow up to 195 liters per minute. Her forced expiratory flow is 25 to 75% increase to 2.5 liters per second, which is a 28% improvement. Her borderline normal lung volumes, as measured by the forced vital capacity, and FEV1 and her flows are in the normal range, although there is some improvement seen post-bronchodilator. This would indicate that she has some airway reactivity. I have reviewed her recent chest x-ray. I've also reviewed the echocardiogram report, which shows normal. She has developed dyspnea with exertion. The etiology is unknown, but reactive airways disease could be a potential cause. She has rhinitis, likely vasomotor, and infectious. I'm going to start her on albuterol HFA as ProAir and Proventil 2 puffs via Inspir Ease every 4 hours and 15 minutes prior to vigorous exercise. She can use either Claritin 10 milligrams or Zyrtec 10 milligrams daily for rhinitis symptoms, and she may also use Sudafed 30 milligrams every 6 hours for significant nasal congestion. Continue these medications for 2 months and meet me thereafter.
Okay, thank you, doctor.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, You'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Autonomic dysfunction can be caused by a myriad of factors, and more than one can occur even in the same patient. Degenerative neurologic diseases such as Parkinson's disease, multiple system atrophy, and pure autonomic failure can lead to conditions such as orthostatic hypertension and fixed heart rate responses. An immune-mediated attack, either idiopathic or paraneoplastic, can be a source of focal or generalized autonomic dysfunction, as seen in Guillain-Barré syndrome or autoimmune autonomic ganglionopathy. Metabolic and toxic damage, as in diabetes mellitus, amyloidosis, and Fabry disease, can also contribute. Genetic disorders like dopamine beta-hydroxylase deficiency and familial dysautonomia can play a part. Additionally, abnormal reflex responses in conditions like carotid sinus hypersensitivity, vasovagal syncope, and other neurally mediated syncopes, including postural tachycardia syndrome, can factor in. Abnormal sweating responses, as in generalized or focal hyperhidrosis due to excessive activation, can also occur. Traumatic or tumoral spinal cord injuries at different levels can present with the so-called autonomic dysreflexia.
Now look at question 26.
Aging is characteristic to all living organisms, and humans often regard it with some level of fear and trepidation. The thought of losing smooth, clear, and bright skin in exchange for folds and wrinkles seems enough to put a damper on many a spirit. The good news is, a number of anti-aging procedures can be effective in ridding your skin of dullness and excess pigmentation as you grow older. When the process is completed by a certified surgeon, skin procedures such as lasers, chemical peels, facelifts, microdermabrasion, and several others can be used to improve the quality of your skin and combat the effects of aging.
Now look at question 27.
I've brought my son in, and he has been scratching and has eczema on his hands and his arms, and it's been going on for a while now. I just don't know.
Know what to do. Oh, so have you been here before previously? Have you got any information on the eczema?
I thought it would go away. I thought it would be a childhood thing or just a temporary thing that would go away.
Well, some people certainly seem like they grow out of it because they've suffered with it as a child. And there could be a multitude of reasons why they don't have it as an adult. It could be that you're using specific products, like washing powder, that are aggravating the eczema. And as people grow up, they tend to change their routine and it doesn't affect it anymore. It could be irritated.
Okay. What about people who have told me food allergies can be a thing? I think that might make sense because he's just started eating solid foods and things like that.
Certainly, people have allergies towards certain foods, and with regards to causing or aggravating eczema, That's something you could look into further. But personally, I don't think there's going to be anything that's going to be massively contributing to that.
Now look at question 28.
Well, this can't be right. Monkeypox? This article says that it's a rare disease caused by the monkeypox virus. It usually originates in Central and West African countries, but there have been 2 cases in the UK so far. The article says that it spreads after close contact with infected people and that the symptoms are usually fever, headache, muscle ache, backache, chills, fatigue, and swollen lymph nodes. Plus, a rash can develop that covers the sufferer's face and other parts of the body. It looks like they've contained the disease in the UK, and the 2 people who've got the disease aren't linked to one another, but both of them have recently been on trips to West Africa. Thankfully, transmission from infected people to the general population is extremely unlikely, and the 2 patients are getting the best care from some of the best tropical disease specialists in the world.
Now look at question 29.
This news article has to be a joke. A local school that asked parents to respect the rights of others who do not want to vaccinate their children is now struggling to manage a severe chickenpox outbreak. An estimated 80 pupils have been diagnosed with the infectious disease within the last fortnight after the condition was contracted by an unvaccinated 9-year-old student. Those with the condition make up a quarter of the entire school, whose records showed that only 73.2% of pupils had been vaccinated against chickenpox, compared with a national figure of 92.1%. I can't believe this could happen, considering the fact that the government in Victoria has introduced the no jab, no play policy that was supposed to mean that all children enrolling in preschools and nurseries had to have up-to-date vaccinations or pre-approved exemption. They really should have made it mandatory for primary and secondary schools too.
Now look at question 30.
Hello, my name is Stephen Williamson, one of the doctors here, and you must be Mike. What brings you here to see me today, young man?
I fell off my bike, sir.
Is that how you've ended up with that nasty gash there?
Yes, I think I was going too fast. I was trying to make my bike go up on one wheel and I lost control. My mom says I'll have a scar for the rest of my life.
Well, not necessarily the rest of your life, but you will be able to see something there until it fades. I'm going to stitch that up for you to stop the bleeding, and so you don't get an infection.
Okay, will it hurt?
First, I'll clean and numb the area, and I'll give you a local anesthetic. You may feel a little tug during the procedure, but it's more irritating than painful. I'll also book you an appointment to come back in 7 to 14 days to have them removed. It would have healed by then. In the meantime, I need you to keep the wound bandaged and dry, at least for the first day. And you'll need to wash around the wound with clean water at least twice a day. I'll prescribe you some jelly to put on it too.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Cardiac and renal function are intricately interdependent. Failure of either of these organs causes injury to the other in a vicious cycle of worsening function. We are discussing acute exacerbation of heart failure or acute cardiorenal syndrome today, resulting in acute kidney injury, a common cause for admission to the intensive care unit. Let's examine the clinical definition, pathophysiology, and hemodynamic derangement clues that help in diagnosing and treating cardiorenal syndromes. Cardiorenal syndromes are a group of interconnected disorders involving the heart and kidneys, classified based on whether the problem is acute or chronic, and whether the primary problem is in the heart, the kidneys, or another organ. The term cardiorenal syndrome indicates the heart is primarily affected, while renocardiac syndrome means the kidneys are primarily involved. Secondary cardiorenal syndrome points to another organ being the primary issue. Acute renal dysfunction can be defined using a KEEN, acute kidney injury network, and RIFLE, risk, injury, failure, loss of kidney function, and end-stage kidney disease classifications. On the other hand, acute cardiac dysfunction includes distinct conditions like acute heart failure and cardiogenic shock. Cardiogenic shock is characterized by an abrupt compromise in cardiac pump functioning, resulting in global hypoperfusion severe enough to cause systemic organ damage. Acute heart failure is defined as rapidly or gradually worsening symptoms and signs of congestive heart failure due to worsening pulmonary or systemic congestion. Hypovolemia is a hallmark of acute heart failure, whereas patients with cardiogenic shock may be hypovolemic or normovolemic. Renal injury is caused by distinct mechanisms in these two conditions, leading to different therapeutic implications. In acute heart failure, renal venous congestion, causing reduced renal perfusion, is considered the major hemodynamic mechanism of renal injury. In cardiogenic shock, a critical decrease of cardiac pump function reduces renal perfusion. As such, the ideal definition of acute cardiorenal syndrome should outline the distinct pathophysiology and provide therapeutic options. Renal injury due to cardiogenic shock given its different mechanisms, should not be included in its definition. Thus, our discussion of acute cardiorenal syndrome is limited to renal injury caused by acute heart failure. Multiple mechanisms contribute to the pathophysiology of cardiorenal syndrome. Sympathetic hyperactivity is a compensatory mechanism in heart failure and can be aggravated if cardiac output is further decreased. This results in constriction of afferent and efferent arterioles, decreased renal perfusion, and increased tubular sodium and water reabsorption. Different strategies can help prevent acute cardiorenal syndrome. An optimal outpatient diuretic regimen to avoid hypervolemia is crucial. Patients with advanced congestive heart failure should be monitored thoroughly in dedicated heart failure clinics until their diuretic regimen is optimized. They should be advised to regularly check their weight and seek medical opinion if they observe any increase in weight or a decrease in urine output.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
The two main categories of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is a large group of diseases with different symptoms, treatments, and outcomes. The name of the type of non-Hodgkin lymphoma may include several descriptive terms that can be difficult to understand. Lymphomas arise from lymphocytes, a type of white blood cell, which are of two types, T cells and B cells. Both help in killing infectious agents. However, they do so in slightly different ways. Depending on the type of lymphocyte that turns into the cancer cell, patients may have a T cell or a B cell lymphoma. B cell non-Hodgkin lymphoma is the more common type. There are many different types of B cell and T cell lymphomas, each behaving differently. Pathologists, when performing a biopsy of the tumor, define the cancers in terms of grade. High-grade lymphoma cells look quite different from normal cells and tend to grow aggressively. Low-grade lymphomas have cells that look much more similar to normal cells and multiply gradually. Intermediate-grade lymphomas fall somewhere in the middle. The behavior of these types is also described as indolent and aggressive. What the pathologist describes as high-grade or intermediate-grade lymphoma usually grows fast in the body, so these two types are considered aggressive non-Hodgkin lymphoma. Surprisingly, aggressive non-Hodgkin lymphoma often responds better to treatment, and many people with aggressive non-Hodgkin lymphoma are cured if they are diagnosed early. The most common kind of aggressive lymphoma is diffuse large B-cell lymphoma. On the other hand, low-grade non-Hodgkin lymphoma grows gradually and these lymphomas are therefore called indolent non-Hodgkin lymphoma. This group of non-Hodgkin lymphoma doesn't give rise to too many symptoms, but they are also long-standing and less likely to be cured. The most common kind of indolent lymphoma is follicular lymphoma. Sometimes indolent lymphomas can transform into more aggressive forms. The majority of lymphomas are nodal lymphomas, meaning they originate in the lymph nodes. However, lymphomas can arise anywhere. When the lymphoma is mainly present in nodes, it's called nodal disease. Occasionally, most of the lymphoma may be in an organ that is not a part of the lymph system, such as the skin, the stomach, or the brain. In such a condition, the lymphoma is referred to as extranodal. Therefore, nodal and extranodal refer to the primary site of the disease. A lymphoma can develop in a lymph node and then involve other parts at a later stage. However, in such a case, it is still considered a nodal lymphoma, but is said to have extranodal involvement. In follicular lymphoma, the cancer cells arrange themselves in spherical clusters called follicles. In diffuse non-Hodgkin lymphoma, the cells are spread around without any clustering. Most of the time, low-grade non-Hodgkin lymphoma is follicular, and intermediate or high-grade non-Hodgkin lymphoma is diffuse. Finally, non-Hodgkin lymphomas are also described as common or rare based on the statistics of new cases every year.